So, dear students, we are going to start our lecture. So, first of all, I want to say about the 8 components of balanced smile. So here we see that there is such components as a lip line, a smile arch, an upper lip curvature, lateral negative space, smile symmetry, occlusal frontal plane, dental components, and gingival components. First of all, it's the lip line. The lip line is the amount of vertical tooth exposure in smiling, in other words, the height of the upper lip relative to the maxillary central incisors. As a general guideline, the lip line is optimal when the upper lip reaches the gingival margin. So as we could see here, displaying the total cervico-incisal length of the maxillary central incisors. So we do not see the lower incisors, we see only the full height of the upper central incisors, along with the interproximal gingiva. A high lip line exposes the clinical crowns plus a contiguous band of gingival tissue, whereas a low lip line displays less than 75% of the maxillary anterior teeth. Because female lip lines are on average 1.5 millimeters higher than male lip lines, for 1 to 2 millimeters of gingival display at maximum smile could be considered normal for females. Dental professionals have been conditioned to see a gummy smile as undesirable, but some gingival display is certainly acceptable and is even considered a sign of youthful appearance. The starting point of a smile is the lip line at rest, with an average maxillary incisor display of 1.91 millimeter in men and nearly twice that amount, 3.40 millimeters in women. With aging, there is a gradual decrease in exposure of the maxillary incisors at rest and to a much lesser degree in smiling. This steady decline in maxillary tooth exposure at rest is accompanied by an increase in mandibular incisor display. It is important to differentiate between the post-smile and the spontaneous smile. The post-smile is the voluntary expression made when introduced to someone or when taking a passport photograph orthodontic records. A post-smile is repeatable. Studies have found little difference among numerous consecutive photographs of post-smiles by the same individuals. A spontaneous smile, in contrast, is involuntary, natural, and driven by emotions. So, with all the muscles of facial expression involved, a spontaneous smile always has more lip elevation than a post-smile. Most studies refer to the post-smile because it is reproducible and can therefore be used as a reference position. Well, the upper lip length. The upper lip length, it is one component of these 8 components of balanced smile. So the average lip length at rest, as measured from subnasal to the most inferior portion of the upper lip at the midline, is about 23 millimeters in males and 20 millimeters in females. What is significant, however, is the relationship of the upper lip to the maxillary incisors and the commissures of the mouth. Lip length normal should be roughly equal to the commissure height, which is the vertical distance between the commissure and the horizontal line from a subnasalia. So here you can see in this picture, made a little bit closer, lip length compared to commissure height in picture A. It is a normal lip length at rest. And on the picture B, we could see a reverse resting lip line. A short lip length related to commissure height results in an anesthetic reverse resting upper lip line. It is not easy to alter commissure height, but lip lengthening is possible with lip surgery, either as a single procedure or in combination with the leftward 1 osteotomy. There is also a surgery procedure. In adolescence, short upper lip relative to commercial height could be considered normal because of the lip lengthening that continues even after vertical skeletal growth is complete. It is interesting to note that a short upper lip is not always associated with a high lip line. On the contrary, the upper lip was found to be longer in a gingival display group than in a non-displayed sample. So the next is the lip elevation. In smiling, the upper lip is elevated by about 80% of its original length, displaying 10 millimeters of the maxillary incisors. Women have 3 to 5% more lip elevation than men. Actually, there is considerable individual variability in upper lip elevation from rest position to the full smile, ranging from 2 to 12 millimeters with an average of 7 or 8 millimeters. If a gingival smile is caused by a hypermobile lip, it would be a mistake to correct it with aggressive incisor intrusion and maxillary impaction surgery, because that would result in little or no incisor display at rest, and thus make the patient look older. Excessive lip elevation should therefore be recognized as a limiting factor. Likewise, if a low lip line is due to a hypermobile lip, excessive incisor extrusion will result in an overbite with excessive incisor display at rest. So in the picture you could see patient with limited lip elevation from rest position, from rest position to full smile. Absence of gingival display on the picture B. Here we can see a patient with excessive lip elevation from rest position to full smile. So we call this a gummy smile. It's not must be normal. If there is in our patient at the age of 11 or for women or 12 for males, we can use some orthobatic treatment, for example, hypohergia, to rotate the maxillary, to make the intrusion of the anterior segments and the extrusion of the posterior segments, and to correct this gummy smile. After orthodontics and maxillary impaction surgery, it is the picture B and C. So we could see that there is the picture C. It's not ideal, but it is much better than it was before. More surgical impaction would have resulted in no incisor display at rest in the picture B. So vertical maxillary height. The importance of the vertical position of the maxilla in tooth display has been demonstrated in both prosthetic dentistry and orthodontic surgery. When upper lip length and mobility are normal, a gingival smile with excessive incisor display at rest can be attributed to vertical maxillary excess. This kind of skeletal gingival smile is generally associated with excessive lower facial height. Conversely, a low lip line with no incisor display at rest is skeletal when associated with inadequate lower facial height due to a vertically deficient maxilla. On the picture A, it is a patient with low lip line due to a vertical maxillary deficiency, and it's his lateral cephalogram. Vertical maxillary height. The best reference for impacting or lengthening the maxilla is the incisor display at rest, taking upper lip length and any incisor attribution into account. The full smile does not make a good reference, partly because of the individual variation in lip mobility. A short upper lip should not be treated by shortening the maxilla unless the facial outline can accommodate such a change. It should also be noted that in maxillary impaction, the upper lip shortens by as much as 50% of the surgical skeleton intrusion. Crown height. The average vertical height of the maxillary central incisor is about 10.6 millimeters in males and 9.8 millimeters in females. A short crown can be due to attribution or excessive gingival encroachment if there is little or no incisor display at rest, but the lip line is normal and smiling. The crown height can be increased incisively with the cosmetic dentistry. A gingivectomy or a crown lengthening procedure with vertical crestal bone removal is recommended when short clinical crowns are associated with a gingival smile and a normal incisor display at rest. So here is a patient with gingival smile, as you could see here, overbite, and short clinical crowns. After orthodontic maxillary incisor intrusion and crown lengthening surgery. So if we will use only intrusion or only, for example, intrusion, we could make this gummy smile better. But without lengthening of the clinical crowns of these two, it would not be a good result. So this patient, they used the incisor intrusion to delay the gummy smile and crown lengthening surgery to make a balanced smile. Vertical dental height. As mentioned earlier, the incisor exposure at rest rather than overbite determines the vertical position of the incisal edge, all other factors being equal. Therefore, a deep bite should be corrected by maxillary incisor intrusion in a patient with excessive incisor display at rest, but with posterior extrusion and lower incisor intrusion in a patient with normal lip line at rest. The opposite applies to an open bite, which should be corrected by maxillary incisor intrusion if there is an adequate incisor display at rest, but with posterior intrusion and a lower incisor extrusion if the lip line is normal at rest. What about incisor inclination? Proclined maxillary incisors, whether in a class 2 division 1 malocclusion or in class 3 compensation, tend to reduce the incisor display at rest and in smile. On the other hand, upright retroclined maxillary incisors, as seen in class 2 division 2 malocclusion or after orthodontic retraction without jaw control, tend to increase the incisor display. A maxillary incisor inclination can best be assessed on profile and oblique smiling photographs, which should become standard of orthodontic records, orthodontic and prosthetic records. So here we could see lip line with reduced incisor display due to proclined maxillary incisors. So we could see that the nasolabial angle, it is wider than must be. So using the orthodontic treatment, we make retrocline of the central incisors and the profile of the patient become much better. Yeah, on the picture B is a normal incisor display on orthodontic uprighting of maxillary incisors. But for example, if the patient had a good profile, the nasolabial angle is normal, but the patient have a proclined incisor display, we must understand that if we will make a good dentition, we will lose a good profile of this patient. So, for example, we need to use for example, the anchorage of the group A. So we don't need to retrocline the incisors. We need to make a mesialization of the molars and premolars, or even make an orthodontic surgery. So when we treat our patients, first of all, we need to look at the facial profile of our patient, not on the teeth and the dentition. On the first place, it is the profile of our patient. The smile arch. The smile arch is the relationship between a hypothetical curve drawn along the edges of the maxillary anterior teeth and the inner contour of the lower lip in the post-smile. The curvature of the incisal edge appears to be more pronounced for women than for men and tends to flatten with age. The curvature of the lower lip is usually more pronounced in younger smiles. In an optimal smile arch described as consonant, the curvature of the maxillary incisal edge coincides with or parallels the border of the lower lip in smiling. The lower lip can either touch, not touch, or slightly cover the upper incisal edge. In one study of untreated subjects, the patients whose lower lips touched or did not touch the incisal edge had a higher aesthetic score than those patients whose incisal edge was slightly covered. In a non-consonant smile arch, the maxillary incisal edges are either flat or reverse relative to the curvature of the lower lip. Smile arches were found to be flatter in orthodontically treated patients than in untreated group with normal occlusion. For example, if we not only use, for example, the edgewise appliance treatment or treatment with a straight wire appliance, we understand that this line it will be flat. So as here, that the flatter in orthodontically small arch were found to be flatter in orthodontically treated patients than in an untreated group, resulting in a denture mouth appearance. In another study, flattening of the smile arch was found in 1/3 of the 30 treated patients, but in only 2 of the 30 untreated subjects. So as we could see, for example, if we will work as the orthodontics for a lot of years, we could see the orthodontic treated patients before they will see it or come in our office because they are flattened. Upper lip curvature. The upper lip curvature is assessed from the central position of the corner of the mouth in smiling. It is upward when the corner of the mouth is higher than the central position, straight when the corner of the mouth and the central position are at the same level, and downward when the corner of the mouth is lower than the central position. Upward and straight lip curvatures are considered more aesthetic than downward lip curvatures. So upward and straight, as we could see in the picture A and B, they are more aesthetically than downward. In a non-orthodontic population with normal occlusions, upward lip curvatures were rare, but straight and downward lip curvatures were almost equally prevalent. Because it is a muscle-driven position, upper lip curvature is not subject to alteration by orthodontic therapy. A downward lip curvature could therefore be considered a limiting factor in achieving an optimal smile. Lateral negative spaces. The transverse dimension of the smile is also referred to as a transverse dental projection. Lateral negative space is the buccal corridor between the posterior teeth and the corner of the mouth in smiling. Although the prosthodontic literature describes the smile lacking buccal corridors as unrealistic looking and denture-like, orthodontists refer to buccal corridors as negative spaces to be eliminated by transverse maxillary expansion. Transverse maxillary expansion, you understand that we could move our teeth only in bone. So, for example, if the patient have a narrow maxillary arch, we could not make an expansion, a great expansion, only using the orthodontic fixed appliance. For example, a wider orthodontic fixed appliance because we could remove teeth only in bones. So if we need to close these buccal corridors, for example, we need to make, first of all, the rapid maxillary expansion. If it is young patient, if it is an old patient, we use the maxillary skeletal expansion, MSC, or surgically assisted rapid palatal expansion, and only then we use the fixed implantation. So you need to understand that we don't make a wide dental maxillary arch if it was too close. First of all, we need to make an expansion, a skeletal expansion. A first molar to first molar smile is often advocated in orthodontics, but is considered evidence of a poorly constructed denture in prosthodontics. In studies measuring the number of teeth displayed in the smiles of young subjects with normal occlusions, those displaying the first molars were ranked the highest aesthetically. So, as we understand here, this patient is more aesthetically than these with these buccal corridors. But if we talk about our orthodontic stability, we understand that there are limitation factors during our orthodontic treatment. They are the anterior limit, posterior limit, lateral limit. So the lateral limits, it is the widening of the arch. So, and if we talk about the stable result, we do not overexpand the maxillary arch. So, for example, if the patient have a very narrow maxillary arch, if we'll make even using the bone expansion, MSC, or surgically assisted rapid palatal expansion, our result would be not stable. So we need to understand this. A first molar display was found in only 3.7% of one sample. However, with most of the subjects displaying only the second premolars, in fact, non-extraction treatment of maxillary expansion does not necessarily improve the attractiveness of the smile. Research has shown that premolar extraction does not lead to arch constriction or a widening of buccal corridors. Furthermore, repeated surveys of lay persons have failed to establish an adverse aesthetic perception of negative spaces. Arch form also affects the transverse dimension of the smile. A broad arch is more likely to fill the buccal corridors than a narrow and a constricted arch. In addition, buccal corridors are heavily influenced by the anterior-posterior position of maxilla relative to the lip drape. Moving the maxilla forward will reduce the negative space because a wider portion of the arch will come forward to fill the intercommissure space. In smiling, the width of the mouth increases by as much as 30%, therefore an excessive transverse lip extension in smiling would theoretically produce a wider buccal corridor. So the next component is the smile symmetry. The smile symmetry, the relative position of the corners of the mouth in the vertical plane, can be assessed by the parallelism of the commissure and pupillary lines. Although the commissures move up and lateral in smiling, studies have shown a difference in the amount and direction of movement between the right and left sides. A large differential elevation of the upper lip in an asymmetrical smile may be due to a deficiency of muscular tonus on one side of the face. Myofunctional exercises have been recommended to help overcome this deficiency and restore smile symmetry. An oblique commissure line is an asymmetrical smile can give the illusion of a transverse count of the maxilla or a skeletal asymmetry. So here is the patient with a symmetrical smile due to deficiency of muscle tonus. Muscle tonus on the left side in this patient. Frontal occlusal plane. The frontal occlusal plane is represented by a line running from the tip of the right canine to the tip of the left canine. A transverse can be caused by differential eruption of maxillary anterior teeth or a skeletal asymmetry of the mandible. If we see these patients with this such asymmetry, we need to make not only the lateral cephalogram but also the cephalogram in the frontal view to measure the difference between the left and the right side. The relationship of the maxilla cannot be seen in intraoral imaged or static casts, and smile photographs can also be misleading. Therefore, clinical examination and digital video documentation are essential in making a differential diagnosis between smile asymmetry, a candid occlusal plane, and facial asymmetry. Having the patient bite on a tongue blade or a mouth mirror in the premolar area during the clinical examination is a good way to recognize an asymmetrical cant of the maxillary frontal occlusal plane. In the next component, there is a dental component. The first 6 components of the smile considered their relationship between the teeth and lips, and the way the lips and soft tissue frame and the smile. A pleasant smile also depends on the quality and beauty of the dental elements it contains and their harmonious integration. Dental components of the smile include the size, shape, color, alignment, and crown angulation, or we call it also the tip of the teeth, the midline symmetry, and arch symmetry. The dental midline is an important focal point in an aesthetic smile. A practical and reliable method of locating the facial midline, which normally coincides with the dental midline, is to use 2 anatomical landmarks, such as nasion and the base of the philtrum, known as the Cupid's bow. So if we see on our patient and we see that midline the midline at the upper on the maxillary and the mandibular, it doesn't falls. So we see on the philtrum first of all. So we do not understand if the maxillary have rotation or mandibular have a rotation. To know which jaw is guilty, as to say, we saw on the philtrum. So looking on the philtrum, we understand that if the maxillary diastema is such as the philtrum on the one line with the philtrum, so we have a problem with the lower jaw, with the mandible. And on the other hand, if the philtrum is on the one line with the midline diastema on the mandibular, we have a problem with the upper jaw, with the maxillum. So it is important to know. The midline diastema we see, we look only on the philtrum. Okay. A line drawn between these 2 landmarks not only locates the facial midline but also determines its direction. The parallelism between the maxillary central incisor midline and the facial midline is more important than the coincidence between the dental and facial midlines. In fact, in one study, a 4 mm maxillary midline deviation was not detected by dentists or lay persons, whereas a 2 mm deviation in incisor angulation was rated as noticeable unattractive. A mild midline discrepancy is acceptable as long as the interproximal contact area, connector space, between the maxillary central incisors is vertical. Arch symmetry. It is also important in achieving a balanced smile, which is why cases with peg-shaped or missing lateral incisors are particularly challenging. Other factors that can disturb the continuity of the dental composition include midline diastemas and lack of interproximal contacts. Is the patient with unattractive maxillary central incisors midline angulation, referred to as a canted midline. Here's the patient with arch asymmetry due to peg-shaped lateral incisor during smile, a symmetrical arch after extraction of backolateral and orthodontic space closure. Gingival components. The gingival components of the smile are the column, the contour, the texture, and the height of the gingiva. Inclination, blunted pupil, open gingival embouchures, and uneven gingival margins detract from the aesthetic quality of the smile. The space created by a missing papilla above the central incisor contact point, referred to as the black triangle, may be caused by root divergence, triangular teeth, or advanced periodontal disease. Orthodontic root paralleling and flattening of the mesial surfaces of the central incisors, followed by space closure, will lengthen this contact area and move it apically toward the papilla. The gingival margins of the central incisors are normally at the same level or slightly lower than those of the canines, while the gingival margins of the lateral incisors are lower than those of the central incisors. The gingival margin discrepancies may be caused by attrition of the incisal edge, ankylosis due to trauma in a growing patient, overcrowding, or delayed migration of the gingival tissue. The gingival margins can be leveled by orthodontic intrusion or extrusion or by periodontal surgery, depending on the lip line, the crown height, and the gingival levels of the adjacent teeth.
Sorry, I have a question. Yes, if we proceed with the, like you said, periodontal surgery, which is a gingivectomy, and put a crown, it wouldn't go back to the, we will not go back to the initial situation. I mean, the gingiva will not grow again and cover maybe the crown after a gingivectomy.
In most situations, no, there is no relapse, but we need to say that when we work with our patient, we have special documents in where
legal consentment.
When in these documents there is a registration that there could be a percent of relapse. So we couldn't work without it. And in our orthodontic treatment patients, if they after orthodontic treatment they do not use retention appliance, for example, the back Howley appliance, it will be a relapse. So in our documentation they make.
So if we have a relapse of the gingiva, we could proceed again with a gingivectomy, another gingivectomy, right?
Yeah, we could try maybe another way. We also, when we are going to make a gingival ectomy, we need to understand that the height of our of the central incisors, it is not normal, because if the patient, for example, have a normal height of these central incisors, and we will make a gingivectomy, it will have too big.
Yes.
So when we're working with patients, we see if the patient, for example, have a gummy smile. If it is a young patient, we use orthopedic treatment. Women from they have a maximum peak of growth. If you talk about women at the age of 11, if you talk about men, it's the age of 12 years. Then we could use the orthopedic treatment to decrease this gummy smile. But if it is an adult patient, we use the micro implants. We insert it.
Okay.
We inserted them between these central incisors and make an intrusion of the central sizes. If it is a very difficult situation, we use an orthodontic surgery. About this term, I don't have this in this lecture, but you could search it on the PubMed or Angle Orthodontics or Clinical Journal of Orthodontics. There is
articles about this.
Yeah, there is an article that during which we have the height of the gummy smile. We use, for example, I don't know correctly. I can make a mistake. For example, if it's 3 millimeters of the gummy smile, we make an intrusion. If it is from 2 to 4, we make an intrusion with the temporary anchorage device. If it is more, then we use the orthodontic surgery.
Okay.
There must be an article in the PubMed.
Okay, I will look for it. Thank you. Thank you so much.
Mm-hmm. So okay, it was. It is the part of our last presentation. These 8 components. But today we need to talk about the impression materials. So if you're interested in impression materials, we'll begin next lecture. So I don't think. How are you looking about this? So I can just send you this presentation and you could read at home about this TMG. So this is all information from the American books about the. No, what was about these 8 balance smart was from the article, and other information is from American books. So I think that if you okay, so I send you another lecture. Yeah, when we work with the patients with, for example, when I make not only, no, for example, fiberectomy after orthodontic treatment, we make a fiberectomy to make the percentage of the relapse lower. Even on this fiberectomy, we could have complications, and then we need to make a repeated surgical procedure. So it is really, if we clinically work with our patients, it's really hard to work with gingiva and with the soft tissue because there is a percent of relapse. So impression materials. Classification of impression materials, application features of impression materials, and clinical practice. So impression materials are used to copy the teeth by surrounding oral structures by creating a dental impression poured with the dental plaster to fabricate a dental cast. This procedure provides a two-dimensional and accurate mouth replica, allowing dental work even in the absence of the patient. Dental models enable dentists to perform a better diagnosis and treatment planning since the teeth can be meticulously visualized and studied from angles that are difficult to see the patient's mouth. Particular treatments such as removable and fixed prostheses can be executed thanks to dental casts. The final restoration of prosthesis fit depends on how accurately the impression materials has recorded the tissue details. What about these dental casts, dental models in our practice when we, for example, work orthodontically with our patients? Due to our law, we must to make these dental casts before treatment, and they must be in the clinic after we treated our patients for 5 years. So it is very important, and during our clinical practice, to make these models. If you want to see how there must be made these dental models in America, there is an Tweet Foundation. I don't know if there is a video in internet. I don't have this video. I saw this video on the lecture one time. So the Tweet Foundation, they have a video how to make these dental guess how they must be made. So if you would ever saw this,
I will look for it on. I will look for it on internet. Yes.
Yeah. I don't know. I really don't know if there is in internet. But if you one time will look, so just see. It's very interesting how they need to be made correctly. Because, for example, in Ukraine, Zaporizhia is in our in Zaporizhia, in Kiev, all these dental cases they are made incorrectly. Okay. History impression materials. Wax was the only impression material used in dentistry until the mid-19th century, when gutta first appeared. Then in 1957, Charles Stent created a thermoplastic modeling compound similar to today's impression compound. Still, the problem with this material was that it was rigid and could not reproduce undercut areas. All the impression materials used until that date became rigid after setting and could not copy the oral tissues accurately. Thus, there was always a need for impression material that could remain elastic even after setting. That is when agar, a reversible hydrocolloid manufactured from algae, was introduced in dentistry. Although this jelly-like material was elastic, it required a complicated procedure to be used as an impression material. When the algae used to manufacture agar was unavailable during the Second World War, Americans used local algae to manufacture another elastic impression material known as alginate, which we use nowadays to make impression. We use an alginate, which has gained popularity since then. Alginate and agar have disadvantages like dimension instability and low tear strength, which led to the manufacture of elastomeric, also known as rubber-based impression materials. So when we work with alginate, we need to fill it with gypsum during the 20 minutes after we take this impression. It's if we talk about the alginate, because the alginate have a high risk of the shrinkage after 20 minutes. So we need to fill it with the gypsum during the 20 minutes after we take an impression. Okay. Dental impression materials are used to copy oral tissues, create a dental impression, and then pour gypsum into them to produce a dental cast. A dental cast is used to analyze and diagnose a clinical case, manufacture removable and fixed prostheses, and build occlusal spleens and mouth guards. Beyond the teeth, impression materials are utilized to fabricate maxillofacial prostheses such as obturators, ear prostheses, and prostheses of the eyes. If we talk about the orthodontic treatment of patient, dental cast when we use to make an individual dental card of our patient. For example, if the patient has a narrow mandibula, we make an individual card of this patient, and we adjust the maxilla during to the mandibula, not vice versa. So it is important to know that when we work orthodontically with our patients, the size of the wire on the lower on the mandible must be greater, must be bigger than in the maxillary. So we adjust the maxillary to the mandible. It is very important during the stability of our orthodontic treatment. Another way, if the patient has a narrow dental arch of the maxillary, for example, this, and we want to use, for example, some Damon Q brackets, which have a very wide wire. For example, the width of this wire would be this. So we understand that we could not tip the lower incisors on the lower molars. We could not tip them. As you understand that we have lateral limits, and if we talk about the expansion on the mandibular, it is only the only way to expand the mandibular. It is to make a lateral tipping of the molars. So we could make only the tip. We could not make a skeletal expansion as on the maxillary. So we talk that we adjust maxillary arch to the mandibular arch to make this stability. If you, for example, would treat our patient this way, that will give him a Damon Q brackets with a very wide wire, for example, for this patient. We'll have a good result. But after we will take off our brackets, it would be a great risk of relapse, a great risk. So, yeah.
Yes.
A great risk of relapse. So what we could make, for example, we could not use we could use, for example, Damon Q brackets, but we need to use the wire, which would be not such wide. Ну, будет хуже, как бы не будет широкой. It will be not such wide as this wire. And it would have, for example, this size, or only to expand the mandibular by tipping. This result would be good, but the best result to make the individual dental arch card, you could see this video in the YouTube. It is from II.3 Foundation. They make an individual dental arch card, and then they fabricate this wire individually to this patient. So it is if we talk about the dental cast and our orthodontical treatment of our patients. Classification of impression materials based on use for primary impressions. They are the alginate, impression compound, elastomeric putty. For secondary impressions, light body elastomers and zinc oxide eugenol. Based on satin reaction, they are reversible impression compound, impression waxes and agar, and irreversible or chemical alginate, impression plaster, elastomeric impression materials. Based on the state of the impression material after setting in the oral cavity, rigid, impression compound, zinc oxide eugenol, impression plaster, impression waxes, elastics, the alginate, agar, polysulfides, addition and condensation, silicones, and polyethylene. Polyethylene is the best impression materials on our days, but there is nuance that it is not cheap. It has a very high price. So for example, if we talk about the Zaporizhia, not in each clinic there is polyethylene because it has a very high value. But it is a great material for making impressions, polyethylene. Based on compression of underlying tissues, they are metastatic impression plaster or light body elastomers and mucocompressive impression compound and putty elastomers. Irreversible alginate. Okay, alginate. Alginate is an elastic, irreversible hydrocolloid impression material. Irreversible hydrocolloid impressions form an inseparable part of indirect restorations. Alginate is one of the most frequently used dental materials, and alginate impression is a simple, cost-effective, and indispensable part of dental practice. Yet very few people can make alginate impressions just right the first time. For many years, alginate impression material has been a staple of most dental practices. They form a major bulk of our clinical practice even today. Therefore, it becomes mandatory to understand the material and follow certain fundamental guidelines for flawless, predictable impressions and hence avoid repeat impressions and restorations. So if we talk about our clinical use of alginate, for example, orthodontic treatment, when we want to make, for example, Frankel appliance, functional appliance, for example, it could be a Frankel appliance, we need to make the impressions using the alginate. We do not need to make to use the silicone, because an alginate it would impress the soft tissue in their passive in their passive state. So it is very important to make such appliances, for example, as a Frankel appliance. So we use alginate in our practice. If we will make, for example, rapid maxillary expansion appliance, we use a silicone. But if we want to make the patient functional appliance, we need to use only the alginate. Okay, chemistry and setting. Okay, let's talk about the selection of impression tray. As is the case with all impression materials, it is important to select the correct tray for the dental arch. The stock trays to be selected for alginate should be perforated. As you can see, this we use for alginate. Alginate adhesives can be used apart from perforations for retention of alginate to the impression tray. Use of alginate adhesives overcomes displacing forces during withdrawal of the impression from the mouth. Alginate adhesives are available as paint on or spray on. The use of brush can result in cross-infection of patients. After application of alginate adhesive, it is allowed to dry for 5 minutes. More frequently, the stock trays would require some customization, as you could see on this patient, in the form of tray modification. Modifications can be done with works, tracing stick, impression compound, or heavy-bodied silicone, depending on the operator's convenience. Most frequently, we use works, but we also use the silicone to make the customization of this tray. Modified impression tray must be placed in the mouth and muscle trimmed. Before making an impression, the dental arch to be impressed should be examined carefully. If there are any existing fixed partial dentures, the pontics required to be blocked out with wax so that the impression does not tear in these regions. If the patient has a high palatal vault, tracing stick compound can be used in the center of the maxillary tray to reduce the bulk of alginate impression material. In case teeth are missing, in one posterior quadrant, modeling compound is softened in a water bath and placed in the tray to make an impression of the edentulous areas. The imprints of the teeth should be cut out with a sharp knife so that the compound has definite stops against the maxillary tuberosity. Compound is trimmed so that from 3 to 5 millimeters of clearance between compound and mucosa exists, except in posterior palatal seal area. This compound modification of the impression tray should be firmly adhering to the tray. If not, wax spatula is heated to merge with the tray borders carefully. The compound surface is softened with a flame and a ball of cotton is pressed into the surface for a few seconds, leaving short cotton fibers embedded. The cotton fibers, they provide retention for alginate material. So you could see these fibers and then provide the addition retention for the alginate material. Impression tray is placed in cold water to harden this compound. Mixing and loading an alginate. Commonly used alginate materials are supplied in containers. A scoop is provided for measuring the powder, and a cylindrical plastic measuring cylinder for measuring the water proportion. Some water supplies contain large amounts of minerals that can affect the accuracy and setting time of the alginate. In such cases, distilled or demineralized water can be used. We used distilled water to make our alginate impression. Mixing is initiated by adding measured quantity of water to clean, flexible rubber mold. This is followed by the addition of correctly proportioned powder. So the first we place the water, and only then we added this our powder. Only in this subsequence. So first of all, it is the water, and only then.
First of all, we put the water, then the powder, not the powder, then the water.
Yes. If we talk about theoretical part, it is right to make this way. First of all, it is the water, and only then we add the powder.
But usually we do the contrary. It's more easy to
make another way. Yes.
Yes, and to control the mixture.
Yes. Yeah. As you could see from this slide, they use the special scoop. They use this measuring cylinder. But if we clinically work, it is not always these components with alginate. For example, I buy the alginate, but they couldn't give me this scoop and this cylinder because they don't have them. So we need to buy them separately. It is one way. Another way that the patients, they have different size of the jaw. For example, if the jaw is really wide, this portion of this material may be maybe not enough to make a right impression. So we need to make a big portion. But if we talk theoretically, they will make this way. This is followed by the addition of correctly proportioned powder. Colder water. We need to use only the cold water, not the heat water, and you need to make a.
Yes, of course.
Make to check the temperature of the water, because if you would use, for example, the hot water and this alginate will harden before you put this tray in the mouth of the patient.
Yes, exactly.
Yeah, so we need to use only the cold water. Setting time should be controlled by varying water temperature and not the consistency of mix. Mixing should be rapid with the wide bladed spatula. We use not the metal spatula, we use the plastic spatula because they are softer, and it is better to make this mixture with a plastic spatula. The resultant mix should be creamy in consistency, as in this photo, but must not drip of the spatula when lifted from the bowl. So when you lift the spatula, it must not drip. So it is the right consistency of this alginate.
But likely, Unfortunately, we have these new apparatus that will mix it for you, and you have the measures, the right measures to use. So it makes it easy.
If you have a special apparatus, it's the best way.
It's done, yes.
Mechanical mixing of alginate in devices such as the alginator or the combination unit ensures that the alginate mix is the same each time they are mixed. Mixing time is 60 seconds for hand spatulation and 15 seconds for mechanical. The required amount of material is loaded onto the tray. The tray must be filled with the impression material up to the tray borders. So it is important up to these borders. So it must be on this same way. And any excess unsupported material at the periphery must be removed with the mixing spatula. The surface of the alginate is smoothed with a wet gloved finger. So you make a wet gloved finger and you make a smooth surface. So for dentate cases, occlusal surfaces of teeth should be blown off with an air syringe to remove debris and saliva in order to minimize air blows. At the same time, the teeth should not be left to dry completely, since alginate material sticks to dry teeth as the thin film overlying the teeth is removed. When the surfaces are dry, the alginate radicals in the impression material form chemical bonds with the hydroxyapatite crystals of the enamel. Hence, alginate tears upon removal. Having the patient rinse with water and mouthwash mixture will eliminate mucin and lower the surface tension, thereby eliminating air bubbles. If repetitive impressions are made with alginate, the film over the teeth is lost and getting a satisfactory impression is prevented. While repeating impressions, the patient must be asked to rinse the mouth to rehydrate and produce a new film over the teeth for accurate impression. So we need not to forget about this, the reghydrate, the reghydration. Okay, the mixed alginate should be rubbed onto the occlusal surface with a gloved finger to fill the occlusal grooves, allowing accurate reproduction of the occlusal tooth anatomy. Some alginate must be placed in the palatal vault. If a patient, for example, have a Gothic palatal, then we can make this. Impression tray is positioned in the mouth by retracting the patient's lips on one side with the mouth mirror or gloved finger. We use a gloved finger, and on the other side by rotating the tray into the mouth. The tray has to be centered in position in the mouth. So the center of this tray must be in one line with the center of the incisors. The soft tissues, especially labial flange, should be relieved and manipulated for the alginate to flow into the sulci and record the details. When tray is seated, pressure should be released immediately, and the tray should be held lightly in place to prevent unseating. So we make an immediate pressure, and we held our tray lightly to prevent the unseating. It is imperative to release pressure as soon as the tray is seated. Alginate material starts setting from the tooth surface to the impression tray, and pressure will cause impression to set under strain. When we remove the impression from mouth, these strains will be released, causing distortion and an inaccurate cast. Moving the impression tray during gelation will incorporate similar strains. So when we remove, the impression has to be removed with a firm, quick snap. The impression should not be rocked or twisted before or during removal of the impression. This is to minimize the time for which the set material is distorted as it moves over the teeth. The seal between tissues and the impression may have to be removed before removing the maxillary impression by gently pushing with a gloved finger or by using air syringe into the buccal sulcus. During removal of the maxillary impression, the operator's index fingers of both the hands should be in the buccal sulcus to break the seal, while thumb holds the tray handle and the other fingers support the impression tray. Okay. Storage and disinfection. Self-alginate undergoes imbibition and syneresis if left in a normal clinical environment. So the time before cast pouring is critical when we use alginate. After being removed from the mouth, the alginate impression should be washed with a water spray, disinfected by means of the practitioner's choice or disinfection procedures, and dried until the shine just disappears. The impression has to be covered with damp gauze and left in a Ziploc plastic bag until the cast is powered. Cast pouring must be delayed for 10 minutes. So here we could see the time at 10 minutes, but this alginate which we work, it is Zermac, it is larger 20 minutes. But from 10 to 20 minutes, but we couldn't make these dental casts during them 2 days or 3 days, so it would be incorrect. We have from 10 to 20 minutes. Distortion can be a problem if disinfection guidelines are not strictly adhered to. Hydrocolloids, they are hydrophilic in nature, hence they swell if immersed in water or disinfectant. We could use disinfectant sprays for alginate impressions. Immersion disinfectants like 1% sodium hypochlorite or 2% glutaraldehyd can result in changes, and hence the quality of the impression surface may not be impaired if the recommended period of time is strictly followed. So when we make the disinfection of our alginate impressions, we do not use, in Ukraine, we do not use this spray. We have a special container with the disinfectants, and we put these trays in this container. But it is very important that the concentration of the solution concentration must be right, because the dental assistants, they could make a higher concentration than it must be, and when you will put your tray with alginate, it would be spoiled, and you need to make a new impression. So it is very important.
Yeah. Then you have to do it again. Yes.
Yeah. There must be the right concentration, because it is they think that if they make a higher concentration, it is good for. Yes. Yes, but when you put the tray, you take it over the container, you see it. We need to make a new.
And that's what they usually do.
Yes.
Assistants, they usually do that. I don't know why, but they usually do that.
Yes, this is a clinical tips. Cast fabrication. Alginate impressions should be poured using vacuum mixed stone. So if you have in your clinic vacuum mixed stone, it's the best. Yes. And the vibrator. A thick mix can trap air bubbles. The stone should be allowed to set in trays with the teeth down. If tray is turned upside down onto base of stone, there would be a tendency for water to rise the highest point cusp tips. This can result in very soft cusps on the model. Inverting the tray may also bend alginate away from tray if excess material has not been trimmed away prior to pouring. Cast has to be removed immediately after adequate set, otherwise the model would have moth-eaten appearance. About this cast fabrication, for example, we make if I work when I make this cast for my patients, I use the gypsum 4 class for the dental area, and the gypsum of the 3rd class to make the it is called the plinth of this dental cast. It is all made in one time, so you make the gypsum of the 4th class, you put it into your impression, and then you make gypsum of the 3rd class and you put it. So because if you will make this during a few time, there would be no contact between the gypsum of the 4th class and the 3rd class. So and when we make this cast fabrication with the gypsum of the 4th class, this tray with impression must be laid downward, so that the heavily particulars of this gyps they could go down. That is why we use the gypsum of the 4th class and the 3rd class. Such materials as a reversible hydrocolloid. Honestly say, we do not use them in Ukraine. We don't have these reversible hydrocolloid materials, but in America they use them. I don't know if you use this in Morocco, but in America it is.
No.
Yes. No, you don't have these reversible hydrocolloid materials. But in America, it is very popular to use these reversible hydrocolloid materials. So you could see, that they were originally derived as a natural product of kelp. However, the material currently available in considerable different. If powered immediately, reversible hydrocolloid produce casts of excellent dimensional accuracy and acceptable surface detail. At elevated temperature, it changes from a gel to a solid. This change is reversible, that is, as the material cools, the viscous fluid sol is converted to an elastic gel. Reversible hydrocolloid is supplied in a range of viscosities. In general, a heavy-bodied tray material is used with a less viscous syringe material. The required temperature changes are affected with a special condition you need and water-cooled impression tray. So it is difficult that we need to use this condition you need special water-cooled impression tray, maybe because they have such difficult moments we work with them, we don't use them in Ukraine. So it is not even, so you could even buy them in Ukraine. But in America it is.
They are not available.
Yeah, they're not available to buy, yes. But in America they are very popular, such as the polysulfide polymer. They are commonly known as rubber bases. They were introduced in the early to mid-line 1950s. They were received enthusiastically by dentists because they had better dimensional stability and tear strength than the hydrocolloid materials. Nevertheless, they should be powered as soon as possible after impression making. Delays of more than an hour result in clinically significant dimensional change. These polysulfide polymer, they are also not available in Ukraine, so you couldn't buy even to use this. But if we talk about condensation silicone, there is a wide use of this silicone in Ukraine. So we use Speedex, another another species of these condensation silicones. So it is very popular in our country. Some of polysulfide's disadvantages have been overcome by condensation silicone, which is essentially odorless and can be pigmented to virtually any shade. Unfortunately, its dimensional stability is less than that of polysulfide, but greater than that of reversible hydrocolloid. An advantage of this silicone is its relatively short setting time in mouth. As a result, patients tend to prefer condensation silicone over polysulfide. In addition, condensation silicone is also less affected by high operating room temperatures and humidity.
Here in Morocco, we have the polyether impression for a precise impression.
Polyether you use, yes?
Yes, polyether impression, yeah. We use the
polyether.
We also use the silicone, but more often the polyether.
The polyether, it's a great choice, but it's
an American product too, so
it's very expensive to buy. Yes.
Yes.
Polyether.
Yes, it's very expensive. But usually we use the 100% when we have cases of implants. If we are not using the scanner, we also use the polyether. But lately it's more, for individual crowns or implants, it's a scanning and that's it. No implants, no alginate, no nothing. It's more easier.
Yeah. So in Zaporizhia, for example, I'm working in 5 clinics, but in no one there is a polyether because it's very expensive. Mostly we use this silicone alginates, but polyether it's very expensive.
It's for the VIP patients, not for everybody.
Yes.
Yes.
Your polyether it was developed in Germany in the mid-1960s, has a polymerization mechanism like those of the other elastomers. No volatile byproduct is formed, which results in excellent dimensional stability. In addition, its polymerization shrinkage is unusually low in comparison with most room temperature QA polymer systems. With the high dimensional stability of polyether, accurate casts can be produced when the material is powered more than a day after the impression has been made. This is especially useful when powering the impression immediately is impossible or inconvenient. Another advantage of polyether is its short setting time in the mouth. For this reason, polyether is used by many practitioners. So it's the use of the polyether nowadays is the best choice. Additional silicone. They were introduced as a dental impression material in the 1970s, also known as polyvinyl siloxane or polysiloxane is the generic chemical expression for silicone resins. It is similar in many respects to condensation silicone, except that it has much greater dimensional stability. In our country, in Zaporizhia, for example, we use this additional silicone to make crowns. Honestly say, as I work as an orthodontic, I don't use additional silicone. So if I make an impression, I use the alginate and I use this condensation silicone. For orthodontic, it is not a great.
It's not primordial. I mean, just with silicone and alginates, you have the work done. Yes. This is more for the crowns. Yes.
No, for the crowns. Yeah, because in orthodontical treatment, we don't need to have such precision as, for example, addition of silicone or polyethylene. So clinically, I use this alginate and condensation silicone. Okay, impression trays. The choice of impression material influences tray selection. Reversible hydrocolloids. They require special water-cooled trays. In other ways, we use the prefabricated impression trays to reduce associated distortion in variable associated with the use of such trays. They must have adequate rigidity, and tray design should provide for control of impression material thickness. So retention is provided by perforations, rim locks, and adhesives. So if there is no perforations, we make these perforations, for example, if we don't have in our clinic adhesive spatial, or we make rim locks. Custom trays are fabricated for each patient individually through the use of diagnostic tests. First of all, we make an impression with alginate, then we make a diagnostic test, and after them we could make a custom trays. Yes, adhesive should be applied sufficiently in advance to allow through drying, although they may remain slightly tacky to touch, because evaporation of its volatile solvent is time dependent. It is preferable to apply the adhesive in thin layer. Spray on adhesives have been shown to result in significant resuscitation of polyvinyl siloxane impression materials to both outer polymerizing and photopolymerizing tray materials than to paint on adhesives. Here is the custom tray fabrication. Custom tray improves the accuracy of an elastomeric impression by limiting the volume of the material. In our country, in Zaporizhzhia, we use custom tray only when we move the removable prosthetics. Another way, for example, if we make them orthodontic appliances, we don't need to make this custom tray. If we make crowns, for example, in the implants, we don't need to make this custom tray fabrication. So the custom tray we make only during the removable prosthesis. So it is here we could see the procedure using the outer polymerizing resin. So it could be made by a doctor, or you can make just an impression with alginate, and in the laboratory they'll make you this custom tray. But if you want, you could make it using this outer polymerizing resin. You could make it by yourself. So here is the view of this individual tray or custom tray. So here is the custom tray on the cast. Okay.
Here in Morocco, it's not made by the dentist. It's more made by the protesist.
Yeah. In laboratory, yes.
Yes, in laboratory, yes.
Yes, in Zaporizhzhia, they also, it is mostly made in laboratory. Yeah. As in orthodontic appliances, they also mostly in 95% they are made by laboratory. So on our nowadays, the doctors, they don't want to make this. They want to give the impression to the laboratory and
have it ready to go. Yes.
Yes. They don't want to make this. Yeah. So this is step by step of this photopolymerized resin to make this tray. this the application and impression making with elastomeric materials use this tray. There are difficult techniques. The single mix technique using this apply. So there is an auto mix technique. For example, a machine mixing technique is the best choice if you have, for example, polyethyls with this pentamix. It's the best way. So as you could see, there's an alternative method for improving impression mixing is to use a machine mixer. This system is convenient and produces void free impressions. Reversible hydrocolloid, if you don't use, you could just see as it looks like. So there is a special tray with this water system. So there must be a special condition unit, which is made up of 3 thermostatically controlled water baths. So it's a liquefaction bath for the heavy-bodied tray material and the light-bodied syringe material, a storage bath for maintaining liquefied materials until needed, and a tempering bath bath for reducing the temperature of the heavy-bodied tray material to avoid tissue damage. So it is difficult to make these impressions with. So you need to have this unit. If it is well, it is very difficult to make this impression using the reversible hydrocolloid. Maybe that's why we don't use them in our country. So yeah, you need to select the correct size of water-cooled impression tray, place prefabricated stops, as you could see this with white color, displays the gingiva tissues, or add wash material to the surface of the cathode tray material in the area of the preparation. Submerge the tray in a tempering bath. Yes. Remove cord from the sulcus and flood the sulcus with warm water. Then remove the impression tray from the tempering bath and seat the tray in the patient's mouth. After seating, initiate and maintain the flow of room temperature water through the tray. Hold the tray firmly in the patient's mouth while the impression material is gelling. So you need to hold this tray during this material is becoming gel. And then remove the tray.
You often got bitten by the patient in most of the cases. Yes, they bite.
Yeah. So and yeah, so let's understand it's very difficult procedure. Maybe then we use the silicone or alginate. So, but in American they like these materials.
They are American.
Yes. Here is also a closed mouth impression technique, also called the dual arch or triple tray technique, popular for making impression for a single units and less expensive restorations to conform to the existing occlusion. No, maybe these impressions are made by lazy doctors. So if you don't want to make the impression from the upper jaw, from the lower jaw, to make these bite blocks, you can use this closed mouth impression technique. But you understand if you have, for example, a total total profit is to make a lot of crowns. You couldn't make this impression technique. It is only if you have to make, for example, a 1 crown, one small process. So you can use this technique. Another way, you need to make a full. You need to make a full this impression from the maxillary and from the mandibular. Yeah, disinfection and evaluation. So during the evaluation, we need to see, has the material been properly mixed? An impression that contains visible streaks of base or catalyst material should be rejected. If there is an area where the custom tray shows through, this must be identified and its potential effect on the quality of the impression assessed. So a common error is the rotation and the resulting inaccurate seating of this tray. So don't need to rotate. This can result in the trays contacting several teeth and an uneven thickness of impression material. Okay. So we need to see also if there are any voids, folds, or creases. This should have been avoided by careful technique. However, the impression may still be acceptable when a small defect is present in a non-critical area, away from the margin of a preparated tooth. Careful judgment must be exercised. It's that evaluation. If we called about the prosthetic dentistry, we use a displacement of gingival tissues. Tissue displacement is commonly needed to obtain adequate access to the prepared tooth to expose all necessary surfaces, both prepared and not prepared. This can be achieved by mechanical, chemical, or surgical. Mechanical displacement, it is most effectively achieved by placement of a cord. So you could see this black, it is a cord. Alternatively, paste systems can be used, often in conjunction with directed pressure. Chemicals way to displace the gingival tissues, such as aluminium sulfate or epinephrine. They cause localized foil on one side. The paper side is placed against the dry buccal tissue and adheres to it. In addition, 2 cotton rolls should be placed in the maxillomandibular vestibules to control saliva and displace the cheek laterally. Most often we use this cord to retract the gingiva. There are different sizes of this cord. We can use this cord with the chemical displacement. So we could combine it. So here is the how it we make in our clinic. Isolate the prepared teeth with the cotton rolls. Place saliva evacuators as required, then dry the field with air. Then cut a length of cord sufficient to encircle the tooth. Do not excessively desiccate the tooth because this may lead to post-operative sensitivity. Dip the cord in an astringent solution and squeeze out the excess with a gauze square. An impregnated cord after that can be placed dry but should be moistened in situ to prevent the thin circular epithelium from sticking to it and tearing when it is removed. If a non-braid cord is used, twist it tightly for easier placement. Loop the cord around the tooth, as you could see there, around the tooth, and gently push it into the sulcus with the suitable instruments. It is best to start the interproximal area because the cord can be placed more easily there than facially or lingually. The instrument should be angled toward the tooth so the cord is pushed directly into the sulcus. It should also be angled slightly toward and cord already packed. Otherwise, that might be displaced. A second instrument may aid placement. And evaluation. Difficult with tissue displacement is often the result of gingival inflammation. The inflamed and swollen tissue bleeds easily, preventing access by the impression material. So initial assessment of cord placement can be a useful indicator of the amount of displacement accomplished. When looking at the tooth preparation from the occlusal aspect, the clinician should be able to see the preparation margin circumferentially and the untied cord with no soft tissue folded over it in contact with the tooth. If there is any doubt, assessing displacement by removing the cord is a good idea. What was about the retraction? Hemorrhage control with an infuser syringe. So here is a special syringe. You could use this individual. It's not individual. This single single nose patient, and to make a hemorrhage control. So fill the syringe with ferric sulfate solution and attach the infuser tip. This hollow metal tip contains a cotton filament to help control flow of the medicament. Rub the tip back and forth for approximately 30 seconds over the hemorrhaging area while slowly replenishing the solution by continuous injection. And irrigate the area with an air-water syringe and gently dry the tissues with air. So inspect to determine the degree to which bleeding has diminished. Repeat several times if necessary and place a displacement cord. So before cord removal, slightly moisten the cord with water to minimize the risk of dislodgement of blood clots and renewed hemorrhage. Gently dry the tissues and proceed with impression making. We could also the displacement paste. We don't use Zaporizhia, but some dentists advocate displacement paste as an alternative to cord. The product consists of an aluminum fluoride containing paste that is injected into the dried sulcus with a special delivery gun. Advantages of the system include good hemostasis with less discomfort than traditional cord. However, less tissue displacement is achieved than with cord, which may make dye treatment more problematic. Improved displacement may be achieved if the paste is directed into the sulcus by applying pressure with a hollow cotton rope. You could also use the electrosurgery. And here are the alginate impression making. You can see if the patient have a Gothic palatal, you could using your finger, you could put some alginate on the area of the palatal and then make an impression with alginate. It is if the patient have a Gothic palatal. So it is the end of this lecture.